And I'm presenting on behalf of Medicine 4. Mrs. MB, 53-year-old homemaker from Nellore, presented with the chief complaints of transient weakness of the left upper limb 10 days back. So this transient weakness of the left upper limb was associated with slurring of speech, and there was no history of bowel bladder incontinence, jerky movements of the limbs, and posturing of the limbs. And this was followed by again a transient weakness of the right upper and lower limb 7 days back that was associated with slurring of speech. So both these episodes, it resolved within 15 minutes and there was no residual weakness. And prior to the day of admission, she had transient slurring of speech for which she was admitted for further evaluation and management. She also gives a history of joint pain for the past 20 years, which was predominantly involving the small as well as the large joints of the upper limb and lower limb with mild early morning stiffness that was increased in intensity for the past 1 month. And there was no complaints of fever, rash, no history of chest pain, palpitations, no other complaints. So past history, she has no comorbidities and personal history is postmenopausal and consumes a mixed diet. On examination, the general examination, mainly pallor was present and vitally she was stable, and the central nervous system examination, respiratory and cardiovascular and abdomen examination were normal. So what could be the differentials at this point of time? Okay.
Intermittent APLA syndrome, some cardioembolism.
So at this point of time, it was a recurrent transient focal neurological deficit, and the differentials we considered were recurrent TIA, hemiplegic migraine, and underlying joint pain she had. So it could be a neuropsychiatric manifestation of an underlying connective tissue disease and seizure. So then we went ahead with the baseline investigations. So these were the investigations done on the day of admission. So the labs mainly showed a bicytopenia in the form of a microcytic hypochromic anemia with thrombocytopenia and a retic count of 2.5%, with peripheral smear showing anisopoikilocytosis, but fragmented RBCs were also present. And we see that in the RFT, renal function test, urea and creat were mildly elevated, but then when we repeated the test, it was normal. And there was PT-INR were normal, and this SGOT, SGPT were mildly elevated. So to rule out TIA and to rule out a cardioembolic source of the TIA, we went ahead and did an MRI brain, which was normal, echo, which was normal, and EEG, which was normal. Keeping in mind that she had a chronic joint pain with early morning stiffness that is increased in intensity for 1 month, we went and did an ANA, which showed to be 2+ nucleolar with 3+ cytoplasmic fluorescence and a raised ESR and a CRP. So since there were fragmented RBCs in the peripheral smear, we wanted to estimate. So schistocytes we did, it was 0.3% and a raised LDH of 611. So at this point of time, we had to change our differentials. So what could be the differentials at this point of time? A recurrent transient focal neurological deficit with a bicytopenia with some inflammatory features of joint pain.
Necessarily PTP, APLA syndrome.
At this point of time, the differentials considered were neuropsychiatric manifestations of SLE or thrombotic thrombocytopenic purpura and vasculitis. We further did the autoimmune workup, which showed to be negative except for mild decrease in the complement levels. And for the vasculitis, we did ANCAs, which were negative. And the APLAS workup also we did, which was also negative. During the admission, during the rounds, the patient's attender told that she had one episode of irrelevant conversation, and that following day, when we checked the labs, there was a drop in the hemoglobin with platelet count, and there was a rise in the schistocytes of 0.3%. So we realized that there was something going on with underlying that was active in this patient, and then our suspicion of this thrombotic microangiopathy and thrombotic thrombocytopenic purpura was intensified, and thereby we went ahead and did ADAM TS13 levels, which was less than 0.2% with inhibitors of more than 4 inhibitor units, telling that this is a immune-mediated thrombotic thrombocytopenic purpura. And the following day itself, the lab values also showed an increased reticulocyte count of 4.1%, and the schistocytes also increased to 2.5%. So we diagnose as immune thrombotic thrombocytopenic purpura. So thrombotic thrombocytopenic purpura, it is defined by a clinical criteria of multivessel ischemic symptoms, mainly affecting the brain, and microangiopathic hemolytic anemia with severe thrombocytopenia, occurring in the absence of any apparent causes, with the presence of a severe deficiency of ADAM TS13, less than 30. So what is this ADAM TS13? It's mainly a molecule that circulates in our blood in everybody physiologically. This is mainly this protein. This protein, normally the main function is it cleaves the multimers of von Willebrand factor into monomers. This monomeric form of this von Willebrand factor is less active. That is, it is not prothrombotic. Whereas the multimeric form, this is prothrombotic, and this mainly promotes the microthrombi formation in the circulation, and thereby we get the complications. Like when it is halted in the neurological cerebral vasculature, we get TTP, and if it is a renal vasculature, we get HUS. That. And here it is the diagnostic workup for thrombotic microangiopathy. In this spectrum mainly denotes the spectrum of thrombotic microangiopathy. In our patient, we thought it could be a rheumatological associated thrombotic microangiopathy, but however, the APLA workup as well as the autoimmune workup was negative. So we straight away had to think about thrombotic thrombocytopenic purpura. And for thrombotic thrombocytopenic purpura, we have a score called as the plasmic score. So the prerequisites include, like, there must be a mild kidney injury or absent, and coagulopathy findings must be like the PTINR and all the values must be normal. So our patient fell into these requisites, and we did the ADAM TS13 also. So the plasmic score for our patient came out to be 7. And this ADAM 13 activity, when we sent, it was less than 0.2%. So it shows that there is TTP, and also inhibitor was present. So it is suggesting of an immune thrombotic thrombocytopenic purpura. The components in plasmic score is platelet count less than 30K, which gets a score of 1, creatinine less than 2, which gets a score of 1, INR less than 1.5, score of 1, MCV less than 90, score of 1, and presence of hemolysis. It could be either reticulocyte more than 2.5 or undetectable haptoglobulin or indirect bilirubin greater than 2 milligrams per deciliter. And when there is an absence of active cancer, no prior stem cell or organ transplantation, gets a score of 1 each. The main treatment of thrombotic thrombocytopenic purpura, it's going to be plasma therapy with steroids. Steroids are mainly indicated only in an immune etiology, and rituximab is mainly used in conditions where there is a relapse of the TTP, and whenever there is unresponsive TTP, as we can see in this slide, whenever the standard therapy of TTP is therapeutic plasma exchange plus or minus steroids. And so when there's complete response, we proceed with the same TP. But when there is unresponsive TTP, we try to add rituximab to daily TP. And whenever there is an exacerbation also, we try to add rituximab. And the follow-up is mainly by the estimation of the ADAM TS13 activity. The newer drugs like bortezomib, a proteasome inhibitor that is aiming mainly at plasma cell depletion, and a recombinant ADAM TS13, the evaluation is underway. And recently, an inhibitor of this von Willebrand factor interaction, caplacizumab, is assessed in the Titan trial. So in our patient, once we found out there was decreased ADAM TS13 and increasing schistocytes and reticulocyte, we sought an emergency neurology, hematology, and neurology consult, and a pulse of injection methylprednisolone 1 gram was given for 3 days, and Plex was initiated with cryosupernatant. Generally, it is preferable to use cryosupernatant because it's deficient in von Willebrand factor, so this definitely helps a patient, and patient is doing well. So the learning objectives of this patient, what we realized was whenever there is neurological complaints with thrombocytopenia, we have to think in the back of our mind that it could be thrombotic thrombocytopenic purpura, and plasmic score for TTP should be done. And always one value of cystocytes is not essential. When we have the clinical suspicion, we can repeat it, and if it is increasing, then it could be TTP. Thank you.
So, interesting case. So when the patient came in, what was the plasmic score at that point of time? If you go back and see the parameters, this is
At that point of time, it was 6.
Yeah.
6.
your platelets were more, creat was normal. Sure, interesting case. Again, like sir said, whatever differentials he said, common differentials first, and then in the course of the stay, he had worsening of schistocytes, drop in HB, worsening of platelets. Then you suspected this. Interesting case. Thank you. Any?
Just one question and one comment. It is Adams TS13. Dr. C and team have been working on this for at least 15 years. So if you just do a PubMed search, you'll find many papers. So they are saying there's a thrombotic, especially in non-cirrhotic portal fibrosis. So they have found many of them have decreased Adams TS13 levels. There's a prothrombotic state there. And his boss from Birmingham was doing this work more than 20 years ago. One comment. Second question is, what does the patient have an underlying rheumatological disorder? And what do you think it is? Just show that first slide with the symptoms. Does he have psoriasis by any chance?
No, sir.
She.
No, sir.
So you didn't find any underlying rheumatological?
It was
no,
no, sir. It was undifferentiated. Mild inflammation was a raised.
Uric acid?
It was normal.